Thanks very much. Thanks very much. So you've already had an introduction. I'm Mood. I'm an ENT surgeon, but also had a long-standing interest in sustainability. Don't know if you need to stop sharing your slides so that I can share. I
Yeah.
see. And thanks for joining. I'm sure that for many of you it's quite sunny outside, so you'd probably rather be elsewhere. Okay, I'm just going to share, and you let me know if you're seeing that. Okay. Yeah. Okay, so I've got a few slides just to talk about some of the issues that we face with our supply chain. And my interest in this is long-standing, actually. In 2008, I wrote a little letter when I was a junior doctor saying, hey, perhaps the NHS should be greener. There was someone there who co-wrote that with me called Rachel Sandcliffe, who was a director for something called the Campaign for Greener Healthcare, which later on changed its name to the Centre for Sustainable Healthcare. So I've known Rachel, who's the director, of course, for many years, and we've been thinking about these ideas for a long time. And I think it's culminated really recently. In November, we published a report called Green Surgery that includes all surgical care, includes anesthesia, but principles of what we should be using to decarbonising surgical care pathways. And so, if you've got time, I'd encourage you to have a quick look through that. It's an evidence-based review of everything we could be doing. It's still a nascent field. There's still lots more to learn. But even back then, my particular interest, so back in 2006, I started to question some of the labor conditions in the production of some of our medical products, in particular, starting with surgical instruments. And I'll come on to show you some of that work that I've been doing, or what we've demonstrated is the problems with labor rights in our supply chains. So I'm going to start by just giving you some idea of the scale of the problem. And I'm not specifically talking about obstetrics, gynecology, but there will be lots of parallels because these are generic problems. So 10% of the carbon in health systems is due to medical products. And obviously you're aware 5% of the entire carbon footprint of the nation is the NHS. So it's about 1 in 200 of all carbon emissions of the country are due to medical products. I think that's quite a lot, dominated by linear consumption. And one analysis, the only analysis I've seen, suggests that in the NHS, 73% of products are single use. We know that's about 10 billion medical devices in terms of financial spend, and 240,000 tons per annum of clinical waste, the vast majority of that coming from hospitals. And of course, we know that a lot of that is incinerated because it's medical, and so therefore perhaps it's contaminated, or at least that's the thought process. So to give you some examples of some specific areas, we've got 93 million drapes and gowns in the UK bought every year, 52 million metal instruments, 1.7 billion gloves, and that's pre-pandemic data, and 48 million electrosurgical products. And I find this unbelievable, but this is the data I've checked several times, 4 billion stapling devices. It's a huge sort of volume of goods. And what are the harms? You've already heard some of the introduction, but I'm going to go through these again. First of all, let's talk about carbon. It's the most common metric we measure of climate change, of course, for good reason, because it's a greenhouse gas, but we should not concentrate purely on carbon. So the carbon of different approaches to a hysterectomy, obviously very relevant to gynecology. If you look at these are contemporary data from Cassie Field's lab in New York. If you look at traditional approaches to a hysterectomy, a vaginal approach or abdominal approach, you can see the carbon footprint there on the top two bars is much lower than the more modern approaches, the laparoscopic and the robotic approaches. The A bar there is actually anesthesia, and that is much better than was shown in these graphs because they were using a lot of desflurane. You will probably be aware it's a toxic greenhouse gas, now to be decommissioned in the UK as of this year. But the second biggest component is that single-use products, and that's highlighted by me in that red outline. And you can see that as we move to modern approaches, we move to more and more single-use equipment. So this is a modern phenomenon where we move to single-use equipment, and that is contributing a lot to the carbon footprint of these procedures. And it doesn't need to be this way. There are reusable laparoscopic scissors and instruments. There are now starting to become reusable robotic pieces of equipment. It just, it's rather obvious that the capitalist model seems to support this, but also perhaps some bizarre ideas about infection control. Here's our data. So this is Chantal. Some of you may have heard her speech. She did her PhD under me. We looked at the five most common operations performed in the NHS, and we found that of the products used, more than two-thirds of the carbon was due to single-use products. Surprise, surprise. If you make things and throw them away, it's bad for the planet. Perhaps, none of us were in doubt, but sometimes industry will tell you, no, no, because you've got to decontaminate it, sterilize it. There's a carbon associated with that. Well, yes, there is, but I'll come on to show you that that's all taken account of. And in fact, it doesn't have to be this way, because even in contemporary times, if we do a cataract operation in the UK, has a carbon footprint typical of an operation of about 180 kilograms of CO2. That's the same as driving a petrol car from London to Edinburgh, just one operation. But if you perform the same operation in India, it has 30-fold lower carbon dioxide because of highly efficient systems, reuse of almost all of their equipment, and they actually report lower rates of infection than we report in the UK. So this is the highest standard of care. You cannot argue that they are lowering standards. So when we talk about approaches, we can talk about reduce, reuse, recycle, some of the principles of a circular economy, where we, rather than take, make, throw away, we are trying to keep materials and goods in use for as long as possible. Like the good old days when they made furniture that was designed to last, when they made clothes that were designed to last, rather than the throwaway economy that is so prevalent today. So, surprise, surprise, if you don't use something in the first place, you will save 100% of the carbon. And perhaps some of those procedure packs that are used in hospitals have lots of equipment that we just don't need to be in there. If you reuse from a systematic review, it's been shown you save between 38 and 56% of the carbon for medical products. That's taking account of the decontamination and sterilization. No other single strategy is going to meet that sort of carbon reduction. So if you see a company that says, we make disposable speculi, but we put some solar panels on our roof, I'm really not interested. It's greenwashing. And recycling, it all sounds lovely, but you normally save between 3 and 4% of the carbon if you recycle optimally at home. I'm afraid, yes, I do it as well. We all do it, but it is not the ultimate solution. We should be reusing everything that we can. And in healthcare, recycling is difficult because products are often contaminated. They're often made of multiple different components. By the time you've taken them all apart and tried to recycle them, you may not save any carbon. In fact, you may even cost carbon. So, we've actually just released a few weeks ago a strat policy brief for the greener NHS. We were commissioned by them to say, hey, what should we be doing for medical devices to reduce their environmental impact? And we analysed the data, and we basically said, forget all this carbon footprinting, everything, just maximize to start with the reduce and reuse strategy. And once you do move to reuse, it's actually much, much lower, of course, the carbon from reusable products. There's an example, the second one down, of a vaginal speculum. You can see it's much lower carbon, the reusable version on the top there. But once you've done that, you then need to maximize the sterilization and the carbon of that. So once you've moved to reuse, make the sterilization and decontamination as efficient as possible, but have no doubt that reuse is almost always better. And any company that tells you otherwise has to prove it through independent academic analysis. Otherwise, on first principles, they are wrong. What else? If we throw things away, we get lack of resilience. We can't get supplies. So particularly after Brexit and the COVID pandemic, we had up to nearly 2,000 products in the NHS that we could not get hold of. It's getting better now, but more and more products are unavailable. And that's because we throw things away. Well, part of the problem is because we throw things away. If we kept them, we'd have them in our system. We wouldn't be relying on these bizarre ideas that we keep having to buy things. We've already heard about toxins in our environment, and this is true in healthcare. So our estimates are that 2% of global plastics used in healthcare are 2% of all global plastics are used in healthcare, and there's been huge numbers of microplastics found in the operating theatre. So I'm afraid there are microplastics in every indoor environment. They come from all the plastics that we use, tiny little shards. And unfortunately, they're not just in the environment, they go into humans. So they've been found in every single human tissue that's been sampled: blood, gut, liver, intestines, and lungs. And in the operating theatre, they were found to be 3 times higher than the background level. So these are highly toxic environments we're creating, probably because of all the material that we're opening, plastic packaging and so on. And toxic levels of DEHP, which is a phthalate. It's one of these compounds that's used to soften plastics. It is an endocrine disruptor, and it's not supposed to be at high levels, but when they're monitoring levels in our wastewater from a hospital in central Denmark, these are the data I was given, You can see the red line there is actually what's considered safe, and the blue line is the actual measurements. These are highly toxic levels of DEHP coming out of this waste stream. And by the way, I hope none of you drink plastic bottled water, because that has an average of 240,000 microplastics per litre, and also has been found in many instances to have toxic levels of DEHP. So you are drinking very unhealthy water if you drink bottled water, plastic bottled water. What else? Free market economics operates. So when we want to produce things and throw them away, we want them as cheap as possible. When we want them cheap as possible, we move to what's called global value chains, where we outsource the production to wherever is cheapest and make it as cheap as possible. Unfortunately, that doesn't always come with protection of labor rights. This is actually a factory in Mexico is producing these supports. I think they're elbow supports, and they're going into different boxes. The box on the right is a well-known US brand. The box on the left is a local Mexican brand. It's exactly the same product going into 6 different boxes. So this is free market economics. And what do we know about labor rights abuses? Well, it's very difficult because we don't have transparency of supply chains. Companies don't tell us where their products are made. Norway, who I've been working with, actually, as part of their contractual obligations, asked companies to tell them where their products were being manufactured, where they could get data, and we couldn't always get data. Half of the products were being manufactured, we found, in countries with high risk of labour rights abuse, and we verified this with some data we got from the UK that was difficult to get hold of. So at least half of products we think are manufactured in countries with high risk, and I'll show you that's not just a theoretical risk, it's a real risk. So what are the incentives and barriers that lead to this disposable economy? And I think of 3 main things. First of all, is that perceived risk of infection. I'll come on to show you that often it's a perception rather than a reality. Then there are economic drivers. We think it's cheaper to throw things away, and I'll come on to challenge that as well. And then it's the inability to reuse because, hey, I want to reuse this, but there's no infrastructure to allow me to easily reuse these sorts of products. On the background of all of this, what I'm interested in as an academic in this field is the truth. And the opposite of the truth is sometimes called washing, where you cover up the truth. The classic example of washing is whitewash. Whitewash is where you actually cover up all the truth, and we'll be well versed in this term. Here's some data from ExxonMobil, one of the largest producers of fossil fuels, and the black lines here are actually the data from some modeling that was done, funded by ExxonMobil in the 1970s, where they were looking at what would happen if they carried on burning fossil fuels. The black line shows a prediction from some climate scientists, very nascent field back then, showing what might happen. They covered up all the data. They didn't want anybody to know. They said it wasn't true science. The red lines are actually what's happening now. It's an almost perfect fit. They predicted this was going to happen. Climate change, I don't need to tell you, is nothing new. The first paper on climate change was written by Guy Callender in the UK in 1937, saying there was a problem if we keep on burning fossil fuels to carbon dioxide levels. Greenwashing is where companies might try and cover up something by saying it's good. You'll have heard this term as well. Sometimes we talk about bioplastics. Oh, they're biodegradable. If you look at biodegradation of bioplastics, they release methane, which is a toxic greenhouse gas. Again, these are Cassie Thiel's data looking at a normal plastic or a bioplastic and all the environmental harms. Pretty much exactly the same, whether you use one or the other. So make your product reusable. Don't talk to me about making it out of bioplastic. That's the real challenge here. Blue washing is where companies will say, hey, we're doing some good, we're planting a few trees, making the world a better place, but they're covering up social harms. So, for example, abuse of workers. And I'll come on to show you how Top Glove has been abusing many of its workers in its factories manufacturing gloves. And then I've invented a term which is now accepted by the Infection Prevention Society, something called yellow washing, which is where you use infection control as an excuse for not being able to do what's right, to reuse something. And this, I'm afraid, has become widespread. I'm going to show you some examples of how we've got to this bizarre place where we throw things away. So PPE is the obvious example. We saw that during the COVID pandemic, but this also predates all of this. Back in the 1990s, really, we had this new virus come on called AIDS, and everybody was going to die of AIDS, and we should all be scared. And this was the government messaging around this. Glove use went up when this came up. But of course, we all know that HIV is not spread by skin contact, but it perpetuated these ideas of fear of infection. And then during the pandemic, of course, we were all told to wear this ridiculous PPE, which we did not need because all the evidence shows it didn't make any difference. In fact, if anything, it may have caused harm because we were more likely to spread virus than if we'd washed our hands. We needed to wash our hands. Arguably, we needed to wear masks, but even that's now questioned. We certainly didn't need to wear all this PPE, and we perpetuated these ideas of fear of infection. Infection is usually a failure of process, not materials. We know these data on the PPE increased during the pandemic, but glove volumes also went up. But prior to the pandemic, there's 1.7 billion using the NHS in England. If placed end to end, I think that was almost stretched to the moon. That's the carbon equivalent. We did the first carbon footprint of PPE of driving a petrol car around the earth 8,300 times. What we know is that 60% of glove use is inappropriate. People put on gloves for no good reason, and it's only required when expected contact with potentially infected bodily fluids or broken skin. But I see people putting on gloves just to move patients, just to take a blood pressure. Bizarre ideas. I'm not sure where that's come from. It's a cultural behavioral phenomenon, and we need to stop it. And inappropriate use, as I say, is perpetuated by individuals, institutions, cultures, but it puts patients at risks because some people seem to bizarrely believe that those gloves stop infection. They don't. They're covered in bacteria. We know that 80%, up to 80% of them can be covered in bacteria when they come out of the box. And so you're spreading infection. Much better if you just wash your hands and use clean hands. Perpetuates the public. They start wearing gloves. They expect people to vaccinate wearing gloves. Completely not unnecessary. They even go shopping wearing gloves. Again, completely unnecessary, of course. What happens? Glove use. Malaysia produces 70% of the world's gloves, and they are now constructing new oil refineries to help them to meet this demand. Yet we know that 60% at least of glove use is completely unnecessary. And within Malaysia, within the factories that manufacture there, I'll show you Top Glove, the world's largest manufacturer of gloves, 32 different factory compounds making these gloves for us. But all these people who are packing the gloves are migrant workers, typically coming from Nepal or Bangladesh. Our analysis shows that at least 40% of them have paid illegal recruitment fees of $2,000 to come and have this golden opportunity to work. They are exploited by recruitment agents to pay these fees. Sometimes they paid up to $5,000. Some of them have sold land. When they arrive, they typically work 3 months without a single day off. They will work whatever overtime they can get because they have these huge debts to repay. Some of them historically had their passports confiscated, and so they must live in the accommodation provided by the factory. The video on the right shows you the worst accommodation I've seen, where these workers producing these gloves for Brightway, which comes into the NHS, were living in shipping containers. Their entire existence for 3 years was to live in shipping containers and go to the factory and come back. And that's all they ever saw of Malaysia for 3 years. As you can imagine, the mental health issues were quite severe. But this is all coming into the NHS. And I've shown you some examples, but if you read our report, all of these other glove manufacturers have exactly the same problem. There is endemic abuse of migrant workers in Malaysia, in the gloves industry, but also in other industries, including in electronics and furniture production. So we fund this, and these brands are sometimes relabeled under different brand names and sold to us. There is no glove that is made in the UK. Malaysia and China are where most of our gloves come from. Almost all of our gloves come from. Masks, we found out during the pandemic, some of these were coming from the northwest of China in the Xinjiang province, where masks were being manufactured using forced labor of the Uyghur populations. Perhaps some of you are aware of the genocide of the Uyghur, where this ethnic minority group are forced to assimilate into mainstream Chinese society at threat of physical or sexual torture. You can read the UN report into it because this has been classified as a genocide, and some of the masks that we were wearing were manufactured using state-sponsored forced labor. Textiles. So as I say, 93 million drapes and gowns are used in the UK. The vast majority of those, unfortunately, still are single use. And that contributes a large amount to the carbon footprint, particularly, for example, in orthopedics, where you can see, just one operation for a knee arthroplasty, just the drapes and gowns alone, 72 miles in an average UK car, and carpal tunnel, 21 miles. Oh, sorry, gone the wrong way. So there is misconceptions here. Drapes and gowns must be made of impervious materials. Thin cotton drapes and gowns have no place in orthopedic surgery. That is true because thin cotton drapes and gowns have a risk of causing infection because of their permeability. And there were some studies done that showed that. And I completely agree with the statement. The problem is the statement is 3 decades out of date. There is no cotton drapes and gowns used in the NHS or anywhere in Europe because it is against European regulations. They are unfortunately made of plastics because cotton is obsolete, but these plastics meet requirements for both liquid penetration and microbial penetration. But you can get disposable ones or you can get reusable ones. The reusable ones have 1/3 the carbon footprint and are used 55 to 75 times. So why are we not using reusable? I don't know, because it's perpetuated by these historic ideas of infection risk and perpetuated by industry who will tell you, oh, yes, you have to be careful of infection risk, despite, of course, there is no infection risk. In fact, the reusable products have a much better material quality, higher tensile strength, lower burst and lower particle release. So if you are worried about infection risk, you should actually be using a reusable drape and gown. And here's the most robust decontamination and sterilization anywhere in the world, meeting the standard HTMO 104. Now sterilized using steam sterilization, the same process that is used for surgical instruments. So why is it not good enough? Here's a microbiological monitoring that has to occur. Absolutely fine. The only reason we're not using it is because we haven't changed, and sometimes because of perpetuation by industry. If you look at Austria, 90% of their drapes and gowns are reusable, and I don't think they have any infections. The disposable gowns, we found that again, they were made using forced labor during the pandemic in the northeast of China, using forced North Korean labor, where between 70 and 100% of the salary of these workers was then back to the North Korean state. Metal instruments, obviously relevant to obs and gynae, where you'll also use speculae and then throw them away. 52 million single-use metal instruments, accident emergency, outpatient clinics, ophthalmology, ENT, gynecology, I've just used examples, even removal of sutures. So historically, people used to sterilize everything in their own hospitals, but there was inconsistent or inadequate sterilization. People sometimes use these small autoclaves, and the problem is they weren't always clean. The instruments might have blood on them, and the machines weren't checked for their standards. And then we got this thing called CJD, a prion disease that in genetically susceptible individuals can lead to irreversible brain damage. So these two things with a potentially dangerous, microbe or whatever you want to call it, pathogen, together with inconsistent sterilization, meant that people started to just throw things away. Sounds quite similar to COVID. Of course, you'll be aware that there is no real CJD. We don't see it. And in the 2020s, we have the most robust decontamination and sterilization for instruments, HTMO 101. No person has got CJD from a surgical instrument since the 1970s, when some neurosurgeons stuck a probe in someone's brain, wiped it with alcohol, and stuck it in someone else's brain. We don't do that anymore, and we don't need to really worry about this. But we've got rid of all of the infrastructure, so single use is normal now. Laryngoscope blades, for example, 95% of them are thrown away, and we have single-use instruments for tonsillectomy. And when they were worried about prime protein, it could be in the tonsils. Yet of over 32,000 tonsil specimens, prime protein is found in 0. It's a theoretical risk that does not exist. And it's no different to putting a spoon in your mouth in the canteen. Here's where those disposable metal instruments, including your gynecological speculae, will be made, because 70% of the world's surgical instruments are made in Sialkot in the north of Pakistan. And these people will work on a piece rate. They work basically in sweatshop labor conditions. There's 50,000 laborers. They get paid a piece rate, so they're often indebted, because if they don't work, they have to take advances on their salary to be able to eat. Injuries are not uncommon, sometimes minor, sometimes more serious. Sometimes entire arms are torn out by these machines, but there's no compensation in Pakistan. Of the 50,000 laborers, the last estimate, probably 4,000 to 5,000 are children, some as young as 7, and I've seen 7-year-olds working on these grinding machines. The average age of starting in the industry is 12, and these children don't go to school. Half of them are illiterate. If you interview them, as we have, they hate this work. They don't want to do this work. They want to go and play cricket in the street with their friends. They want to go to school. They want a different opportunity, but no one's prepared to pay for these things. So we want as cheap as possible, and we need to continue to perpetuate the cycles of poverty that keep these people making the instruments cheap as possible so that we can throw them away. and more. We get bizarre ideas. Infection risk from mucosal surfaces. Here's a paper saying the single-use rhinolaryngoscope eliminates a serious potential risk of prion transmission. That's sticking something in someone's nose. I do this, have a look, go, okay, there's nothing there, and let's just throw this electrical piece of equipment away. But there's no known cases of variant CJD being transmitted by surgical instruments or endoscopes. So this is just fear-mongering of infection risk. It doesn't exist for this particular scenario. Infection risk from wax. Bizarre idea that wax can cause some harm. So what we did is we surveyed some practice in various hospitals, and we found huge variation. Some people use gloves and aprons and plastic tubing that they throw away, suction canisters even thrown away after every single wax removal. A bizarre idea. It's an oil that's a natural substance similar to the oil on your skin. It doesn't cause any infection. In fact, the ancient Romans used to eat wax to try and diagnose disease. I'm not suggesting we go back to that, but it just tells you perhaps it's not a toxic substance. Single-use tourniquets, blood pressure cuffs, single-use pulse oximeters, quite normal in the USA. I don't know what infection risk we are dealing with here. Skin is pretty impervious to most bacteria. And I'm now campaigning for single-use door handles because door handles in hospitals are covered in bacteria. And if we're going to throw away tourniquets, we have to throw away door handles every time we open a door, or we could just wash our hands. I'll move on. Financial costs. The problem is our purchasing models are based upon fragmentation of costs by place and time. And that risks false accounting. Is bizarre that we have an operating theatre that says you are responsible for the costs of the gown or the drape, but you're not responsible for the cost of the waste disposal. And when you in fact take account of all of that, the NHS has just done some modelling. Reusable drapes and gowns cost 45% less than the disposable version. So going green is better. And actually, we in our green surgery report, we actually looked at a huge number of case reports of moving to reusable products. And what we found is that every single case that was reported showed financial savings. So for nothing else, going green is going to save money. We've got to stop fragmenting our costs in this way, the false accounting. It's a bizarre way to run a health service. You wouldn't run a business this way. And purchasing models are built on the paradigm of buying things. And instead of buying things, we can move to what's called servitization, where we buy a service. I want you to provide me with a service for example, endoscopes. I'm not going to buy endoscopes, just you have to provide me with a service, which means if you want to make disposable endoscopes, you pay for it, not me. But the problem is, once we've got this model, or economic model of just buying and throwing things away, the industry quite likes that as well and can move into it. Here's planned obsolescence. Here's a drill, System 7, made by a major manufacturer, but they're about to upgrade it to System 8. It looks different on the outside. When you look inside, I can't tell the difference. So why they get rid of System 7? Because I think they're going to stop supporting it soon. What else? Here's something called a harmonic scalpel used to electrosurgically dissect. £600, single use, thrown away. But it can be remanufactured because companies actually do it to save money. You can put new pads on the end of this, but you also have to open this because inside here is a chip that only allows this product to be used once. They have to take the chip out, solder in a new chip that tells the product you can be used again. Eventually it fails because the plastic cannot undergo steam sterilization multiple times. They simply needed to make it out of metal. This is planned obsolescence, 48 million electrosurgical products, but hey, I'm not paying, so we can just throw it away. This gets bizarre. You can label something. No, you can't use that again because of our regulations. Here, this scissors cannot be used again. They are single use only. So we throw away 5.9 million scissors because we're told we can't use them again. You cut some sutures, that's it. Couldn't be used again. Solutions. We need to change these incentives and barriers. I'm going to finish very soon. That perceived risk of infection. So I'm working with the Infection Prevention Society to bring some common sense to infection risk. And then, interestingly, when you get to senior people in the academic world of infection control, they're completely for reuse. They don't know how we ended up in this bizarre idea. I think a lot of it is behavioral microeconomics, where infection control teams locally are making decisions without adequate training or knowledge and are telling people to just throw things away because they're scared. So we need to bring that at a national level. Economic drivers, we need to look at whole system finance and this economic servitization. And I'm working with Aston University and the economics and the servitization economics people there to try and see how we maximize that opportunity in the NHS. and we need human and physical resource for reuse. So expand national infrastructure for textiles and equipment, and explore other methods for sterilisation and decontamination. I'm particularly interested in ultraviolet light, which we are using for some of our NAS endoscopes in ENT, but actually is just coming out now for gynae probes. So you can use this. You just stick it in a light cabinet for 60 seconds and it's decontaminated, ready to go at point of care, really low cost, really low carbon. So I'd encourage you to take that up. So change is required at multiple levels, and this is what I'm working on at the moment. Individuals, please, each of you think, what do I not need to use? Reduce, for example, particularly inappropriate glove use. What can I reuse? What can I move to reusable? Because that is going to protect our planet and protect against those societal harms. Health institutions, I'm working with ENT UK and the Infection Prevention Society, and we will release guidance later this year to support equipment reduce and reuse of instruments and endoscopes. And this will be our recommendation that allows people individually to say, this is what I want to do in my organization. We're launching in a few weeks something called the Circular Healthcare Alliance, where 4 large UK hospitals are coming together to say we will preference reuse of equipment wherever we can. But we need more than this. We need a government that will provide national guidance and infrastructure to support reuse. We need a government that will explore different models of purchasing, including servitization. And if, without getting too political, we need a government that actually believes that climate change is an important agenda for us. I'll finish there. Thank you for your time.
Well, thank you, Mood. What an absolutely eye-opening talk. I really feel like it should be mandated for all NHS employers to listen to you speak, because it would really make people think about what they're using on a daily basis. What we'll do is we'll have questions afterwards. We'll move on to Rachel's talk, if that's okay, but I'm sure there'll be plenty of questions because I've written down a whole 2 A4 sides of interesting things and questions for you, but we'll move on to Rachel. Thank you.
Thanks. Right, let me just try and share my screen. Yeah. Right, someone, is that okay? Can people see that okay? Yeah, good. So yeah, thanks for letting me talk. I'm Rachel Drayton. I'm one of the consultants in sexual health HIV in Cardiff. Yes, what a talk to follow. I feel like my talk's going to be very pedestrian after that hard-hitting, passionate talk, but hopefully it will add a little bit of context into doing something small and on a local level and what we've learned from it. So I can rush through the first couple of slides anyway. It will let me move on. There we are. Because yeah, Mahmood has covered an awful lot of this, but you know, essentially there are some good life cycle analysis from both from the States looking at reusable metal specula versus plastic speculum, and so one by Donoghue a couple of years ago showed that even though the production cost of carbon is a lot higher for a reusable metal specula on repeated uses, there's a carbon saving which just increases over time and over usage. And then another life cycle analysis from the States looked at multiple environmental impacts and found that in all areas apart from ozone depletion, metal outperformed the plastic. And Mahmood again referred to this paper, which looks at was a systematic review of all reusable versus single-use items, and showed there was a lower effect on nearly all environmental impact factors. So in Cardiff, we've moved over, in Cardiff Sexual Health Clinic, we have moved over to metal specula, and I know that Mindy on the call in Brighton has done the same thing down in Brighton, but there are some challenges to implementing it. So like most areas, we got rid of our metal specula many years ago for not quite sure what reason, probably all the reasons that have already been covered. So we needed to purchase some metal specula, which did mean there's an upfront cost to that, because there's an initial outlay, and then obviously as you use them, you'll need to buy fewer single-use items. It's quite difficult to work out, or we found it difficult to work out how many we needed to buy. So we tried to estimate sort of how many specula we were going through and how many sizes, because you want to balance not having too many, because the more times you use it, the more the environmental and carbon saving, but having enough so they're available. So that's quite a challenge to implement. And then Mahmood as well as referenced about looking at where we got our metal specula from. So so we purchased ours from a British manufacturer of medical instruments, which does look at the its supply chains as well, but I'm sure nothing's perfect. But yeah, it's important to look at where you're buying your instruments too. And then Mahmood's also touched on sterilisation. So depending on where you're working, you may have on-site sterilisation available or off-site autoclaving. Most areas don't have their own small autoclave now in small clinics, but if you work on a main hospital site, that should be available, but you do need to think about transport requirements and costs to implement these sorts of changes. And then it's worth having a conversation with your sterilisation units and trying to get them to adequately load the machines and look at the packaging they're using as well, because all of these things have been shown to affect the environmental impact of the sterilisation. So other things to think about with regards to using metal rather than plastic specula, one is about warming them. So most patients will report that they find them cold. So it's thinking about how you warm them safely, but maintaining sterility. So if you're just working in a sexual health clinic or in gynecology or just obstetrics and just using them for examination, you don't need to maintain sterility, because the vagina is not a sterile environment. But obviously, if you're doing a procedure, and in most procedures you'll be doing where you do need a sterile environment, the patient won't be awake to be able to feel that it's cold anyway. So, but you do need to think about how you're going to do that. So the utility of using them and whether they're as or easier to use, and I can touch on that in a minute, and about patient opinion, and then about getting clinicians engaged and trained. So I was just going to share a little bit about the findings we have of when we made this change and implemented it. So we bought 100 medium-sized metal specula just over a year ago, and we negotiated with our local sterilisation service. So we haven't got one off site, but we have transport that regularly goes between the two hospital sites anyway, so there wasn't any additional journeys required. And we put in some staff training and developed some patient information. So we had these posters up on the walls trying to explain to patients the changes that we were going to make. And then I just did a little bit of work looking at the uptake, and after about 5 weeks, we were using metal specula in about two-thirds rather of cases. And I asked the staff how they found it. So about two-thirds, three-quarters of the staff responded, and about half of them said at the time that they were using the metal ones now nearly all of the time or some of the time, and some hadn't had the opportunity to try them. And that they all said they found them as easy or easier to use than the metal ones. So I just did some calculations, just estimating what we thought our carbon savings were. And if we remained at about 30% uptake, then we would save about 0.5 ton of CO2 just in our clinic. But if we got up to 80%, then we'd be looking closer to 2 tons of CO2 equivalent saved in a year, and obviously reduced amount of plastic. And financially, our sterilisation, it was very difficult getting costs from our sterilisation department, but they quoted us about £1 per speculum, which sounds a bit expensive, but then that's about the same cost as buying a plastic speculum. So it was felt to be cost neutral, but as Mahmood said, they all come out of different pots of money, so it was very, very difficult to work out the cost impact, but of course we needed to get an initial investment to buy them. So I'll just present a bit of work that we've done recently, looking at a year on. So we did a survey of patients who come in for a coil procedure, and 79% of them reported they'd had a metal speculum used through their procedure. So that was nice to know, and reassuring to know that that was happening. And we asked them if in the future they were asked what they prefer. So 35% of them said they prefer a metal one in the future, and they quoted things like that they don't feel like a plastic one would be more comfortable and the metal one was just cold. Again, someone else referring to the coldness, but the pros outweighing the cons, and somebody else saying that they prefer a metal one because of the environment. About 46% said they didn't care what kind they had in the future, but 19% they said they would prefer a plastic. And one person references the risk of cross-infection. So, there just needs to be good patient education and information about that. Somebody saying they prefer small ones, so that demonstrates that we need to get some different sizes in clinic. And somebody saying they found the metal speculum painful before. So disappointingly, we did look at our staff a year on, and actually we found that only about half of them were using metal speculum on a regular basis, and half of the staff who answered said they were using them rarely or never. So I suspect that most of the staff who were using them all the time were people who were doing coil clinics, who had been trained to use the metal ones, whereas people who had just had some basic information but no specific training and practice had just slipped back into the old habit of using a plastic specula because they were well, I'll show you why. So this is what comments from the staff survey. Some of the people who preferred the metal said they felt they were stronger, they held the vaginal walls steady, or better visualization of the cervix, that they were easier to use, and people liked them because they knew they had a lower carbon footprint. But the staff who said they liked plastic felt that they were worried about warming the plastic and the metal rather, or that it was harder to use, it was more scary for patients, they weren't always available, the patients chose the metal ones, they preferred a different size, or they just weren't very familiar or confident with them. So our next step is, well, we've already embarked on this, but to do more staff training. So I sit there in clinic now with a leather pelvis and a metal speculum, and whenever somebody comes and asks me for advice, while I'm looking at the patient's results, I get them to practice using a metal speculum on the leather pelvis, but also talking to people about how we discuss it with patients. I'm also acquiring some other specula of different sizes and just to have more available, and then planning to take all the plastic ones out of the clinic room so people can't use them. And then we're looking to take this project forward in other areas within our house board in Cardiff and Vale, but elsewhere as well, to try and encourage other people to make the change. So that's it. That's my little local project about what we've done and some information. So I'll stop sharing.
Thank you, Rachel. It's really good to have a practical example of a change that you've made. So I'm sure a lot of people have found that helpful for how to actually make the steps. If people would like to raise their hands or put questions in the chat, but I'll start with a question for Rachel. So I think we're looking at changing to metal speculums at the RVI as well. And a question that's come up by the midwife that I'm working with is how on earth did we get the change to the plastic ones? And we're looking at doing an audit to work out, like you, how many we need, what sizes. And I just thought, oh, I bet they never did that when they changed to the plastic ones. And I bet they never asked the patients what they thought when they changed to the plastic ones, or the staff. And neither of us have managed to get an answer as to how that happened. But have you got any insights into how these changes happened and when they happened?
No, I know they happened before around the time before I started, which was about 14 years ago. But I don't know when they came in. What I do know is that people who've embraced the change the most back to metal in clinic are the staff who've been around long enough to remember them before and really like them. And actually it's the younger and the newer nurses and members of staff who are a bit cautious about it and unfamiliar. But yeah, I'm not sure. I presume somebody made that decision, but yeah, I'm not.
I think with them placenta pots and galley pots, like I said, I think I started Gobs and Gynae in 2013, and we delivered a placenta in a metal pot, and at some point someone's decided that those need to be plastic, and thank you. And then I also had a question for Mood. I've been reading a lot more recently about endocrine disrupting chemicals. And so when I've been given something to use at work, I try and look what it's made of to find out whether there's these substances in what we're using. But you find very little on the packet. It's actually written what they're made of. How do you find that out? Have you got any experience with that?
This is a big problem. So particularly for plastics, there's typically 200 to 300 compounds added to these plastics. We don't know what those are. There's no requirement for the companies to report on them. I can tell you they're not nice, friendly chemicals. These are toxic chemicals being put and used and put into. So, Yeah, we just don't know what this is. There's all these toxic chemicals potentially around. So I don't have any good way. We should be moving towards a requirement to disclose, because I would say this is a potential harm to our patients. So, I mean, even to come back to, Rachel, your presentation, which was great. I wonder if you told the patients, oh, by the way, if I use this plastic speculum, I'm potentially inserting microplastics and toxic chemicals into your vagina. Is that okay? What would they say then? Because metal is not toxic. A bit of steel is not toxic to our bodies. We don't have that conversation. And I think we're trying to, so we're actually about to start some work on microplastics. And I think we have to adopt what's called a precautionary principle here. Microplastics are found in every human tissue. We should be saying we should not be using them where we have an alternative. I wouldn't want that in my body if I can avoid it. So it's a good question. I don't know the answer.
Thank you. Liz, do you want to ask your question?
Yeah, thanks, Amy. I kind of had two linked questions, but both speakers have kind of answered both in a way. And the first question was really about having those conversations with patients and engaging them in policy change and adding in the environmental aspect for why we do different things. And I know, Rachel, you've said that already. I just wonder if, Mood, in your practice, do you have those conversations with your patients and what their response is?
If I'm honest, I don't. We just do this. I mean, what is the question? What is the question? I'm sorry. What you would like disposable drapes and gowns? It's not for you to decide, actually. Our responsibility is to make sure that you are safe and you have high quality care. Once we've done that, the question is not for the patient choice, I would say. I'm sorry. I know that we like patient choice and I agree with patient choice about treatment options, but actually this is not your choice, I would say. I'm sorry. This is the way we do it. We are safe. We are providing high quality care, so we carry on. I think most patients from our work from the little work that's been done, just want to make sure that they get the high standards of care and they want safe care. We know that patients come in, they expect doctors and nurses to be wearing gloves. It is our job to educate them. So we've sometimes had, oh, why are you not wearing gloves? I said, well, actually, I care about not passing infection onto you. And then they don't really understand, and then I explain it to them. And so that starts a conversation. So patient experience is important, but actually not so important that we damage our planet in the process.
I have to say, we don't give the patients the choice in clinic. The main reason why I did the survey was to demonstrate to staff that actually patients don't mind, which it demonstrated quite well. But we don't ask patients what they prefer. We will use what we'll use. But that was the main reason for doing that, to quieten that proportion of staff who were saying, oh, patients don't like them.
Yeah, and you could be a bit more abrasive and say, oh, are you not worried about inserting microplastics into your patient's body? And then see what they say.
Marissa.
Thank you, all of you both, so much for a really enlightening talk. I've got two questions. The first one is, the session's been recorded. I wondered, is it possible to show just the presentation bits at my local unit? I'm an obstetrician in London. And the second was about the reusable gowns. So we had a pilot of reusable gowns in our maternity theatres a little while ago, and it sort of didn't really come to very much. I had a conversation with our sustainability lead a couple of weeks ago, and my understanding is that one of the barriers to this is about the fact that there is only one service nationally that provides a laundry service for washing gowns. And on the subject, Mahmood, of the greenwashing, I wondered what was your perspective on that, and what's the background to that?
So there are 3 suppliers in the UK at the moment. Ellis, which is the single largest supplier of reusable drapes and gowns. They operate across most of England. Scotland is a bit difficult. They operate in Wales as well. There's another company called Synergy LMS, which is smaller, which also operates. And then there's a relatively new company called Revolution Zero, but that's still relatively small, but they are pioneering, going towards absolute minimal carbon footprint, as you'd imagine, in their setup. So sorry, it's not true. You just need to contact the right people. So Ellis, ELIS, Synergy LMS, or Revolution Zero. They can all supply drapes and gowns. In terms of showing this out anywhere, I'm absolutely happy. No problem from my perspective. Also on our website, the BSMS Sustainable Healthcare, we've actually got some videos and things that people can look at if they're interested, and all the papers we published. Thanks.
Fabulous. Thank you very much.
Yes, Marissa, you'll get the recording. You'll have access to the recording, which you can show to as many people as you like. Amanda.
Hello. Hi. Can you hear me okay? I'm not sure about my sound. Hi. Thanks very much, both of you. Hi. So I've got a question for Mood. So we're lucky in Brighton that we have got a fantastic infection control nurse who is quite forward thinking. Although I don't think I quite appreciated him until we'd come across other hospitals that are really struggling with moving things forward. Have you got any advice for what to advise other hospitals where they are struggling to get through because of the yellow washing that you discussed, because it's their infection control person that's actually stopping them from gloves off, from changing speculums, from stopping gowns, from anything really? Thank you.
Thanks. Yeah, and Mindy's been a great sort of advocate for moving as well to reusable speculi and gloves off. So I suppose, what do we need? Ideally, so what I'm trying to move to with ENT UK as an example is where your body, working with the Infection Prevention Society, so it's going to be a co-badge guidance that says ENT UK and Infection Prevention Society have said this is the standard. That allows people, perhaps your infection control team is worried, they don't want to take the risk, they don't fully understand it, but an authoritative body has said it's okay. So that will hopefully create the environment. Despite that, we still find that some people say, no, you can't do that. And we have to move perhaps to a place where it's mandated, and I'm trying to work with the government to say that. But also, if you want to, and this is difficult because you'd rather work with infection control rather than against them, but I have suggested to people, you could send an email to infection control team and say, oh, can we not sterilize speculi? But hang on, we're using the same thing as our surgical instruments. Are you telling me that our sterile service is not up to standard? If that's true, we have to stop operating immediately. This is a national risk. See what they say then, and ask them to respond in a written email. Because if they don't have an answer, that's it. End of the discussion, I'm afraid.
Can't see any other hands raised at the moment. Has anyone else got any other questions? Alice.
I'll let Alex go first.
Oh, sorry, Alex.
Comment.
Oh, yeah.
I was just wondering whether anyone had managed to, or know anyone who has managed to get rid of the silly disposable cord scissors, the little blue handled scissors in a single-use packet that are then just chucked.
That's one thing I haven't seen, actually. Disposable cord scissors. I haven't seen them, so they're obviously not. They're not everywhere. Hopefully, I won't be seeing them soon.
Yeah, it's an awful Yorkshire thing, but they're not just because they're just normal scissors. So you might see people using them to, cut stitches off or whatever if they haven't got a proper stitch cutter, or cut a dressing. But we have them in all our delivery rooms to hand to daddy to cut the cord, and it's just totally unnecessary. Well, it's good that it's not a problem everywhere else.
That sounds like a
sharps bin. They're just dead after one day.
Yeah. Because it should come in with your delivery set with everything everything else, shouldn't it? Yeah.
Yeah, I would say that's a simple switch. If are you opening a set anyway?
Oh yeah, but there's only one pair of scissors in it, you see. So you just need a set with 2 scissors in.
There you go. You're going to save the trust a lot of money as well, because if you're opening the tray anyway, the cost of sterilizing that tray is the same. And you need to just stop buying those cord cutting things. You can hand a normal pair of scissors to a dad unless you're really worried that they're not mature enough to use them. But yeah.
Marissa.
Thanks, Alex. Alex, all of our scissors are disposable as well. So yeah. Just a question, because you're obviously an engaged group. Has anybody had any experience with using rub don't scrub within maternity? My colleague scrub nurses and ODPs from Australia and the Philippines say it's quite common over here, but I'm yet to find anywhere within my local networks that have tried it out, and there's quite a lot of resistance amongst my colleagues that it's not validated within the maternity setting.
I would just say in the operating theatre, I use rub don't scrub. So this is using alcohol rub after your first sterilizer. So I think your first one, if certainly in surgery, you should be scrubbing as normal. And then in between cases, I just use alcohol. And that's Cochrane reviews. Multiple Cochrane reviews have shown it's equivalent, if not better, to do that. So yes, I don't see why not. If your hands are physically contaminated, then I think you need to actually physically wash them. If not, alcohol is just as good. And that's our, a surgical alcohol rub. Yeah, but yeah, I use that all the time.
Anyone else within obs and gynae? I think the anxiety from my colleagues is, oh, but it's different in surgery, and I sort of point out things like, other theatres, infection is much of a problem. It's not that we are, higher risk.
Why is it different in surgery? I don't understand.
Quite.
It's available at Chelsea and Westminster Hospital. It's variably used, but it's available there.
Okay, that's good to know. Thank you. I'll get
So certainly in surgery, the Green Surgery Report and the Green Theatre Checklist, which we produce, all recommend that that is what's used.
Thank you.
Seems that's not enough though.
Rachel.
It was just coming in on the back end on the scissor conversation. I just thought I'd mention, because I in my naivety didn't know, but certainly the place where we have purchased our metal speculum from, recondition, upgrade, fix things, sharpen scissors. So we had the situation where our scissors, just for cutting coil threads, were blunt, and we were told by our sterilisation department we would just have to throw them away. But actually there are places that you can, because I've had lots of questions about, well, how long's the life cycle of a metal speculum as well. I mean, I would say it's forever if somebody can fix it, if one of the nuts comes off. But I think it's worth bearing that in mind, that there are places out there that will fix reusable metal instruments when they're broken. You'll find them.
There's lots of those places. There's a particular company called Surgical Holdings, which is one of the biggest that will do them. I have no commercial interest, just to be clear, but they can fix an amazing amount of things. And
yeah, that's where we got ours from too.
Yeah. And they show the cost savings. So you'll save carbon and you'll save money. Everybody's happy.
Alice?
I suppose I was just going to make a couple of comments. Yeah, I mean, I've worked in units that have disposable delivery sets, disposable episiotomy sets. I mean, it's absolutely horrendous, the stuff that gets thrown away. I'm aware of a kind of pilot study in Bangor up in North Wales, where they've been trying to change to reusable drapes, and they've demonstrated that it's feasible, cheaper, as safe, and that yet it's 6 months on and it's not happened. And I think that just speaks to that kind of need for that kind of top-down pressure as well, and engagement at that management level. So I think it's really important for us all to be pushing and doing these studies, but I think both levels are just essential.
Yeah, I think, like you say, Alex, especially as a clinician, it wasn't something I knew about at all, like to make these changes. You're not taught as a doctor, like who buys what and why they buy what and where it comes from. It's not something that we know. So yeah, as I said, at the RVI, we're working on a project called Born Green Generation to try and get rid of chemical and plastic exposure. But the amount of people that you need to talk to and link with is just seems quite overwhelming at times to make these quite small changes. Like I say, that at some point probably just someone decided, oh, let's switch these to plastic, and didn't really speak to anyone about it. In terms of what Mood was saying about the Green Theatre Checklist, I don't know if people have seen it, but it's a good way to start in your theatres with a tick list checklist to go through, from everything to the anaesthesia to after the operation as well. And that's part of the Royal College of Surgeons Green Theatre report. Alice.
Thanks, Amy. I was just, I think I just wanted to also just say something before we finish about a collaboration that's started between the Royal College of Obstetricians and Gynecologists and the Centre for Sustainable Healthcare. So they're trying to cut carbon footprints the maternity care, and they're undertaking a literature review in the area as well, but they are going to be later in the year or beginning of next year launching a kind of green team competition within obstetrics and gynecology, which has been done previously within surgery, and they'll be looking for 4 to 6 teams, I think, to undertake sustainability improvement projects within the maternity pathway. So if you're interested, do keep an eye out, because we'll obviously be advertising when the project's open for submissions, and hopefully it'll create a bit of conversation about some of the changes that need to happen in obs and gynae. So just keep an eye out for that. And also, Jeff, thanks for such amazing talks, both of you.
Yeah, thank you for the talks, and thank you everyone for attending this evening. Please join our Women's Health Network on the Centre for Sustainable Healthcare, and please share this evening with any of your colleagues.